Renal disease. Etiology and Pathophysiology. Features of end-stage renal failure/renal replacement include hypertension, elevated serum calcium and calcium phosphate product, anemia, dyslipidemia, uremia, electrolyte imbalance, amyloidosis, beta-2 microglobulin. These result in the following cardiovascular complications via the mechanisms shown in Fig. 88. Left ventricular hypertrophy, myocardial ischemia, impaired ventricular function, ventricular arrhythmias and sudden death, valvular calcification, aortic more than mitral, with rapidly progressive stenosis in a small proportion of cases, and the risk of endocarditis. NB. The heart and renal failure. Abnormal cardiac structure is virtually uniform in patients with end-stage renal disease. Left ventricular hypertrophy is present in 70–80% of patients approaching dialysis, and is linked to anemia and hypertension. Left ventricular dilatation and impairment of systolic and diastolic function are common. These are of course influenced by fluid loading and change, at least partly, following dialysis. Cardiovascular disease is also the major cause of late mortality in renal transplant recipients. Epidemiology. Cardiovascular disease is much commoner in patients receiving renal replacement than the general population and is the most common cause of death in this group, 50%. Those whose renal failure is associated with diabetes and atherosclerotic renovascular disease are at particularly high risk. Investigations. Myocardial ischemia, coronary angiography if intervention or renal transplantation is being considered. Exercise testing, abnormal ECG, and nuclear perfusion imaging have reduced predictive value in these patients. Stress echocardiography may be of value. Echocardiography for assessment of valves, left ventricular function and pericardial effusion. Treatment. Optimize hemoglobin and BP. If symptomatic coronary artery disease is present, bypass grafting is the treatment of choice as the restenosis and coronary event rates post-angioplasty are very high. The indications for surgery in calcific valve disease and endocarditis are the same as in a patient without renal disease. Uremic pericarditis is an indication for dialysis. Cardiac tamponade, of any cause, requires immediate pericardiocentesis. Recurrent effusions may warrant pericardiectomy, a window to enable drainage into the pleural space. NB. Prescribing in renal failure. Be aware that a patient on dialysis may have large fluctuations in serum potassium, with effects on antiarrhythmic therapy. Prognosis. The presence of left ventricular dysfunction in a dialysis patient reduces the 2-year survival rate from 80% to 33%. Acute myocardial infarction and cardiac surgery have a higher mortality than in the general population, but when indicated coronary artery bypass grafting and valve surgery still have an acceptable risk. Prevention. Careful control of phosphate and calcium phosphate product reduces valve calcification. Good aseptic technique is essential when inserting and using dialysis catheters to minimize the risk of infective endocarditis. Aim for good control of BP and serum cholesterol, and maintenance of hematocrit. It is important that the patient stops smoking.